I will share my experience with you with the way we are treating PPH, especially massive bleeding in maternity hospital, and the few changes that we had made so as to at least save our patient as much as possible. And probably we are the first hospital we are using the Clotifact. We will go over also our experience. It is a short experience of around 1 year of using Clotifact fibrinogen concentrate in our patients. So if we want to talk about PPH, we know that PPH by definition is primary or secondary, and it depends on the amount of blood you are losing. Roughly speaking, we are talking about around 500 to start with ml lost by the patients, and this is if lost within the first 24 hours, we call it primary. If it is lost within the 24 up to 6 weeks, this is what we call secondary. And also we categorize the PPH according to the type, whether it's mild and moderate. And what is important in case when you want to put a strategy is to identify your patients, whom you think they are moderate to major bleeding. They have PPH bleeding. Even the minor bleeding, you need to identify them, because in certain conditions they can immediately, or if they are neglected in a way, they can cause, can be one of the major mortality and morbidity for the patients. You cannot identify this? Okay. Well, it is considered as from the, okay, good. This is my name. Okay. Okay. You can skip the first 3 slides. So today I will be talking about the experience that we are doing in maternity hospital, and we feel it's kind of we are happy with our experience because the outcome is really encouraging. Okay. So the agenda that I will be over, because I thought it's a 25 minutes and it turned to be 20 minutes. So, and now the delay that happened, but don't worry. I can skip many slides. Okay, so my agenda will be we talked about the definition, the pregnancy, the pregnant lady. Could you skip? Skip, please. Okay. The pregnant lady is well prepared to manage such a kind of bleeding, because what happens is that there is an increase in the blood volume, there is a hypercoagulable state, and the tourniquet effect of the uterine contraction. To talk briefly about the increase in the blood volume, women in normal pregnancy, they have what is called as an induced hypervolemia, and this is an increase in the blood volume of around 1 to 2 liters. So around 30 to 60% there is an increase, and this is just to prepare her to tolerate such when she has a bleeding, she can't tolerate the loss of this 1 and 2 liter. So put on your mind, whenever she is losing 1 to 2, still the vital signs is not changed. So it doesn't mean that whenever a patient is bleeding and the vital signs are okay or stable, that the patient is not having a serious kind or impending kind of a serious bleeding. So this is what we see in the registry in the WHO. It was considered that hemorrhage was 25% of the, sorry, this interruption. Are you moving it or me? You are? Oh, okay. With the WHO, hemorrhage is responsible for the underlying cause as an underlying causative. Go back, please. Hemorrhage is considered as underlying cause factor in around 25% of maternal death in industrialized and undeveloped countries. So since then, so many guidelines and like in the Royal College guidelines, and also some societies, they have implemented some detailed kind of okay, so in the guideline they sometimes write for you Okay. So beside the guidelines, some societies, they had put kind of a detailed strategy for the way they want to treat their patient whenever they are faced with massive bleeding. And these policies are well written and well organized. Okay. So even when I went, because it was short time, only less than 48, I went over so many guidelines that were written, and there are so many of them. They were in most of the obstetric societies. So we have plenty of resources. But yet, obstetric hemorrhage is still a major problem, and we have one mother dies every 2 minutes, and still as a risk factor, it is still there. This is an old, because of short time I didn't update it, but this is a very nice slide to refer to. This is a UK registry done through between 2003 to 2005, where they have found that hemorrhage is, where they have that it was the third highest cause of mortality in maternal death. Not only that, the problem, this registry, the reports of this registry was very important because they also noticed in even near-miss audit that was one of the major causes of death. And they have published that even in UK, the majority of maternal death due to hemorrhage must be considered preventable. So around 60% of these cases were categorized as a major substandard care. So whenever PPH happen in the hospital, in theater, or anywhere, we have a very well-dedicated team. All of them, they are well-trained, well-experienced in how to deal with it. Yet we are so frustrated sometimes with the outcome of the patient. And this is probably because this is quoted in one of the journals. They said most of these cases, maternal death, occurs in spite of women delivering in hospital staffed by physicians, nurses, and support personnel who are knowledgeable, highly motivated, and well-trained. And often these cases occur in hospitals that have very well-written obstetric hemorrhage protocol in place. So what is killing our patients? Probably this one of the articles that faced the problem truly. They mentioned it frankly. There is no consensus in the treatment of those patients, especially with the transfusion. Nobody can give you and tell you, give this amount, give that time, at proper timing, proper dose. You have to, it's a subjective. You have to study it and see the patient. One patient is quite different than the other. And this is true. The inconsistencies, you can see it. If you review, go ahead, just flip them. These I put just some articles. Articles, they are pushing you, use FFP, use blood, use TEG. Other would say, no, stop, use that. So there are controversy in the whole journals, and because they are trying to help. And some of them, they are with a very low quality kind of studies. Go ahead. Even some of this, although the majority they were pushing for FFP, still now there are articles, they are standing against the use of FFP. They are claiming that it is one of the causes of multi-organ failure in some of the cases. These are all collecting data. Some of the articles would say, go for FFP, other would, no, stop, because it has a side effect. So one of these articles, they mentioned, as if they said, we need a help in this article, because what they said is that we should adopt there should be kind of prospective clinical trials urgently needed. They need to review their process, to apply a new one, and to abandon an old kind of a treatment we are doing. They want kind of an evidence-based treatment and transfusion, and even they were discussing at the end that because there is a delay because of thawing the product, this might add to some risk, adding the risk to the patients. So what really kills the patient? To my point of view, there are two things that kills the patients. It's either factors related to the patient and factors related to the delays. So I'll go first for the three factors that in the patients. These three factors, either the amount of blood loss, or due to the rate of blood loss, or the health status of women. We said that the patient acquired kind of a hypervolemia of 1 to 2 liters, but if the blood loss is more than 40%, this is kind of a life-threatening situation. If we go back to the rate of a blood loss, a patient who bleeds in a rate of 150 per minute, this is a very high-risk condition. Added to that, a health status of the patient. All of you, you know about the 40s that related to the postpartum hemorrhage. And today we are not going to talk about the different reasons of the different reasons. It's related to the tone of the uterus, to the thrombus formation, tissue, and trauma. So, and we will not discuss all the reasons, but the message from the slide is that, click please, is that you need, I know you know all of them, but you need to identify them early, because once you identify all these causes that precipitate to major PPH, you at least solve part of the question, part of the problem, that is 50% of the problem. So what about the 50%, the other 50%? So the real issue during bleeding, acute bleeding, is that this is what we notice. This is my opinion, because I've been involved in so many cases of PPH, and I was in the ICU monitoring, seeing how my colleagues working hard to save the patients. So all of us, we rush in taking the blood sample, but what happens to the blood sample or the tube, nobody notices it. Around 90% of the all engaged in the patient, they are busy with the patient to rescue. But I was watching it, it was left on the table for a time. I consider it is responsible for 3 delays. It's when this test tube doesn't reach the lab at the exact moment, at the time you need, then you would expose the patient to the delay of a diagnosis, delay in transfer the patient, and delay even in the treatment and proper management. So I think now we need to change policies and to implement new strategies, because this is a condition that with high mortality and this is a condition with a high mortality and morbidity. We've been exhausting our resources, because once bleeding starts, we go into coagulopathy, DIC, khalas, all your resources are exhausted. And at the same time, wasted effort from everybody. We want to avoid this substandard care. And there are so many, if you know that there are so many causes are preventable, you want to reach to the standard that you prevent them, to reach that preventable causes. Yes, please. Also, sometimes in a rush, sometimes the whole issue is poorly coordinated. Improper estimation of a quantitation of blood loss. I know the ICU, they have certain bags to estimate the blood loss, but always we ask, what is the bleeding, minor, major, or moderate? So it is a subjective, we don't have. And if we rely on the hemodynamic blood pressure or everything, you need to lose more than 1 liter to tell you the truth. So it is underestimating the problem. And this is, I will not go into the detail of it, but just to just focus that we want to correlate the blood loss with the degree of change in the blood pressure as well as the symptoms. The patient, when she loses around 1,000, there is no changes in the BP or anything. It's just probably she's restless, palpitation, nothing. This can happen from anything. Can you go back, please? But you need only up to 2 liters or 3 liters that you have a marked PP derangement. Next. So we need to change the policy, because we want to prevent minor PPH to go into a very severe and jeopardize the patient's life. And for ourselves in maternity hospital, we need to review, because our lab was quite far away from MOT and ICU. So if you want to change, and you know, the whole process is not only traumatic to the patients and family, but also traumatic to us. So if you want to change, you need to predict, you need to know which patient I need to take care of them, or I need to stratify them. And then you need to prepare yourself in a way that you can offer the best help, and then to handle the problem properly. So this was our guide, where we started our multidisciplinary team, the aim of which is to gather all together and to reach into a successful and a proper management for the patient. So this was done through, back please. This was through reinforcement of interdepartmental meeting and multidisciplinary team. Hematologists were involved right at the beginning once they identify a patient with high risk. So first thing, okay, the first thing that we stratified, we assigned our high-risk patient cases. Yes. And for example, in placenta previa, accreta, percreta, once they are diagnosed, it was agreed that once they are diagnosed, involve the hematologist right from the beginning at the diagnosis stage rather than admission stage. We will prepare the blood, we will improve the patient condition. You will see later on how we are working. So then we will go into, once we identify the risk patient, we will know the proper clinical management of PPH. So the responsible team are assigned, those who are the anesthesia people, we know who to talk to, the group of obstetrician and the hematologist, the whole team of the hematologist. Our role is to prevent. As a hematologist, not only to identify the high-risk cases, I need to improve the patient clinical condition if she's anemic, if there is an underlying coagulation problem, probably even if she needs a lot of blood, she's having an underlying alloantibody or that might delay her process, or her blood transfusion. So prevention is very important. I didn't go into the detail of our preventive measures that we are taking because of the sake of time. Yes, please. So, okay, this is the optimizing hemodynamic status that we go around. We take care, even if we can prepare the patient before, during, or after. Yes. Our aim is to diagnose, to prevent shock rather than to be shocked by the situation, and to treat properly the patient. And even the story doesn't end once this patient is stabilized. We follow up the patient even post-operatively because we want to make sure that she is out of the ICU to the ward, discharge, and even follow up in the OPD. Good. So we updated our policies. And we started to change some of policies we have in the lab. For example, no need for, we receive at any time blood request for any surgical procedure should be sent 2 weeks before the operation, and for blood transfusion at least 5 days before the procedure. From our side in the lab, we try to solve the other 50% of the risk the patient she might have. We try to solve the delay by implementing a new strategy. Yes, please. And among which is that the sample, usually all the samples from ICU, MOT, or high-risk cases, they are handled in a special way. They are handled in hand by hand, and they are, click please. Hand by hand, and any request or tube is left for ICU patient high-risk cases, they should not be put on the desk. If anything is by chance we saw any tube left on the bench from ICU or MOT or high-risk cases, we investigate this issue. So it is hand to hand, and we take all the precaution to finish the test as urgent as possible and to contact and convey the message or the results to our colleagues. For high-risk cases, for high-risk cases, bleeding, we do the test frequently. Go ahead. This is one of the steps that we did, and I think most of the success of our treatment is relying on this. We separated ourselves into 2 parts. I guide the group in the ICU, and the other group is in the lab. I will explain this later on. We introduced because of a distance, we were the first one to introduce point-of-care machine of CBC. And for the last 2 years, I'm looking for a coagulation test that do the 3-parameter for the ICU for such cases. We are using the thromboelastography, but unfortunately, in the literature, its use is so limited. But we can use it now. We have a plan that with every case, major bleeding, we are introducing it. We have to build our own experience with it. For the blood bank, because we receive daily around 30 cross-match, and this takes, every cross-match take half an hour, so we were the first lab to request the fully automated kind of blood bank system, not to tackle the high-risk cases, but at least to work instead of the technologists for those unnecessary cases where the cross-match, type and screen, and our technologists focus on the high-risk cases. We have, this is, flip it quickly. No, not that quick. Go back. So you can stop on this. No, the platelet in PPH, we try as much as possible, according to the case, to maintain it between 50 to 75. Despite the literature, they were pushing around 1.5 to push the fibrinogen. I never used 1.5 as a guideline for me. I always push for above 2 gram per liter. So we introduced, even in our PPH high-risk cases in severe bleeding, I introduced so many with the help of the anesthesia people. We use a tranexamic acid in a dose of 1 gram, repeated every 30 minutes. We have recombinant factor 7 has been used several years without, I'm using it as a prophylactic, as a low dose, high dose. I'm using it especially now for high-risk cases when we know that this is per creta or a very high risk of bleeding. Before I put it as a guideline, when we exhaust our resources of 10 or 8 packed cells, now no, for high-risk cases I used it early, but on my decision, only on my decision. Clot-of-fact is one of the factors that one of the drugs families that we introduced this year. And it is a human product. We used it during this year. It's a human fibrinogen. The one vial has 1.4 gram, and it is in small volume. What's nice about it, I'm not marketing for the company, but this is my experience, and still my experience is premature. So I'm using it for the high-risk cases. Whenever I'm faced with a high risk of bleeding, and the bleeding we know now, if the patient is really bleeding from everywhere, we know. I noticed that the fibrinogen is the first thing that to be knocked down, especially in percreta, in high risk, in amniotic fluid embolism. The way the fibrinogen knocked down, you need a continuous resuscitation with the fibrinogen. That's why, go back, please. I've been using Clot-of-fact successfully with our patient. The last one was one of the worst amniotic fluid. Patient resuscitated and then arrested, and then once she's resuscitated, she went into bleeding from every orifices. We were losing her, but with the help of a Clot-of-fact, this is the time I used a lot of dose of Clot-of-fact because I didn't have time to wait for the cryoprecipitate to be thawed. So I used around 9 gram of Clot-of-fact with the help of cryoprecipitate. Still, I'm not, if you go over literature, there is no consensus with the use of recombinant factor 7, even with, with the Clot-of-fact, even with the recombinant factor 7. But I'm using them, and I'm happy with the way I'm using it in the hospital. I use it because I compare it with the cryoprecipitate. It is readily bottled within less than 1 minute. It is ready for me. I can save the patient by the time thawing is there. The thing that urged me also to do it, because it is very well virally inactivated with the 3 method. Cryoprecipitate is still a human product. So I'll be waiting for the consensus, probably 10 years, I don't know. Okay. This is the way it is.
Time.
So I'll just show this. After we finish, we do discussion. Once the patient stabilizes, we discuss this thing with all our team and also with the lab to know where is the substandard during this case had happened. Okay. So this if you can flip it quickly. Whenever we have an alarm, emergency plan started the way I told you about. But what is the important message I want to give is that the redistribution of the hematologist. We redistribute ourselves into 2 teams. One team in the ICU, guided by me. One of my colleagues goes into the theater because the anesthesia people and the obstetrician, they are so busy. Sometimes I need to know the amount of blood, how much. Is it oozing from the bed of the pelvis? This minor detail, they are so quite busy and they cannot tell me. Because at that time, I can tailor the use of recombinant factor 7 or Clot-of-fact. And we have the major hemorrhagic emergency box. Also, it is, once we have a severe bleeding, 2 units is sent as a rescue, and then we prepare this box as emergency. This constitutes of 4 packed red cells, 4 FFP, and 6 cryo. Go ahead. This is how we monitor. Okay. Finish. The post, finish this, it's okay. This is how we want to push. You want to push the hemoglobin around 8, the platelet around 50 to 70. 50 is safe, but some of the cases, you know, there is impending, it is going on so fast, push it 75 is better. Okay, postpartum management is also continuous with the patient, because at that time we have to know, does she need thromboprophylaxis, improve anemia, and also we need to counsel them in the OPD, because the risk of recurrence is 10% in those cases. Okay, go ahead. Finish. So, stop. This is, I quoted from one of the articles. It represents the whole issue. Having a good protocol that has never been practiced, similar to a football team that studies its play but never works through the timing on the practice field. Or like, back please. خليني أخلصها. Back please. يصير أقول أخرجوا. Anyway, this is the way you want to work it. You want to work it in an organized way, no delay, in a harmony, in a teamwork. Thank you.